Hello, everyone.
Hello everyone. Hello everyone. Hello everyone.
Okay. Am I audible?
Yes.
Okay. Thank you. So some people are still joining. Anyways, we will let them in as we go on. Thank you everyone for joining. We have around 74 and more participants. Welcome to the CME on pediatric anesthesia in resource limited centers, the challenges and opportunities. It is going to be presented by Dr.Anteneh Yifru. So I will introduce him. As he starts sharing his slides. Okay, Dr. Anteneh Yifru is a practicing pediatric anesthesiologist at Yekatit 12 Hospital Medical College here in Addis Ababa. He did his undergraduate degree at Mekelle University in Mekelle, Ethiopia, and he also did his postgraduate studies at St. Paul Hospital Millennium College in Addis Ababa, and he did on top of that his university College of Health Science. He has also worked with the rank of assistant professor of anesthesiology in anesthesia, critical care, and pain medicine for more than 5 years, and he served as department head, academician, clinician, and so he will be highlighting us about pediatric anesthesia in resource-limited countries, the challenge and the opportunities. So the presentation will be around 30 to 40 minutes. We will also have around 25 minutes discussion, question and answer. You can use the chat box for forwarding your questions, as well as you can raise your hand and I can unmute you so that you can forward your questions. And finally, we will have around 10 minutes of summary. Additionally, at the end, there will be a post-webinar quiz. So everyone is supposed to do this post-webinar test, and scoring 50% will be mandatory to get certified of 1.5 CU points. So thank you very much everyone for joining, and we will also allow people on the way. Without further ado, I will invite Dr. Anteneh to present his presentations. Thank you.
Okay, good afternoon, everyone. I hope I'm audible enough for everybody. Thank you, Dr. Blaine, for the introduction. So today the topic of discussion would be pediatric anesthesia in resource limited countries, the opportunities and the challenges. So it's going to be around 25 slides, obviously including the introduction page. If we are going to get enough time, I've also prepared a video which is roughly 8 minutes long, and if you're going to have enough time, I'm going to share that one with you as well. So let me confirm one more time whether I'm audible enough for everybody. You can give me a thumbs up. Can I proceed?
Yes, please. You can
Okay.
proceed.
Okay. So the disclosure is going to be the fact that I'm a pediatric anesthesiologist myself. The reason I made this one as a disclosure is, anesthesia is being provided almost everywhere by different personnel. The fact that I'm a physician anesthesiologist might have some bias on my presentation because it's more or less focusing on that direction. So I just wanted to disclose that. So starting with this famous quote, a safe anesthetic is not necessarily the most expensive one because when people are faced with the locality of service they provide, be it a private practice or in a public service, the justification they tend to give is we don't have this, we don't have that, this thing is not available. Yeah, that is the reality, but we can also improvise on using whatever is available to us because we know anesthesia machine which is brought to us state of the art is expected to last at least 5 to 6 years of service. You come the next month and all the monitoring devices are gone. So part of it maybe resource might be the issue, but clinical governance plays its own part as well. So for us to provide a safe anesthetic, it doesn't necessarily mean that we are going to buy all the fancy stuff. But at the same time, we can utilize the resource that we have, be it a manpower or the consumables. So outlines for this discussion would be the anesthesia workforce, the pediatric anesthesia and surgery, the global burden, the challenges that we have, opportunities, and the potential solutions. Finally, it would be, it's just going to be summarizing. So this is a World Bank income group classification, which is being updated every July of each year, and it is normally based on the gross national income divided by the population of that country, and the income is based on United States dollar. So as you can see, you can say most of sub-Saharan Africa, almost all, is going to be categorized in low. It has 4 classifications, by the way, the World Bank's income classification: low, uh, upper low, upper high, and high income countries. Low, low, and middle high, and higher income countries. So as you can see, Sub-Saharan Africa majority is lying in low and middle income countries classification, and some of the Southeastern Asias are also categorized in that. Those that you see in the green, even for Africa, are considered upper high or higher income countries. So this is where most of the problems, be it war, be it disease, surgical, non-surgical, infectious disease, the burden lies in this group of countries. So coming to the anesthesia workforce, an estimated 1.7 billion children globally lack access to safe and high quality surgical care and anesthesia. This means it's not like a one-time thing, but during their lifespan of the pediatrics age classification, which is being interpreted in different forms in different countries. And many countries, especially the sub-Saharan African countries, lack the minimum physician anesthesia provider ratio of 5 per 100,000 population. In most African countries, the one that you saw as classified as low and middle income countries do even have less than 0.5, while the minimum standard being 5. So I'm going to be sharing with you the picture showing that. So those labeled with red color, it has its own color coding displayed at the top of the screen, where the red one showing the number between 0 and 1, and the green one at the dark green one at the end being 20 plus. So the countries that you see in here labeled red, they have less than one physician anesthesia provider for 100,000 population. And this is from the WFSS workforce, World Federation of Society of Anesthesiologists workforce from 2024 homepage. So coming to global surgical burden, the Lancet Commission, which was research done on 2015, projected the global surgery burden to be 143 million additional surgical procedures are needed each year worldwide, and significant burden on that pediatric population is part of this. That is around 38% of the 143 million additional surgical procedures that are needed are expected to be done for pediatrics age group, and majority of that lie in the countries that we labeled as low and middle income countries, where you don't have the workforce from different departments that are involved in the perioperative management of pediatric surgical patients. And to so the world children, 1.7 billion lack access to appropriate surgical and anesthesia care. This is something that we discussed in the previous slide. During their lifespan, as high as this number, they require the safe anesthesia and surgical service, but they are not getting it. So this is the number that we're talking about. They might get the surgery, but it's not considered to be a safe one, to be categorized as a safe anesthesia and surgical care. And it is estimated that 30% of the global burden of disease are treatable with the surgery. Yet in the low and middle income countries, 80% of the surgical need remains unmet even now. So even though that we can, these low and middle income countries are faced with double burden from surgically treatable and more of infectious ones, it's now becoming obvious that huge impact could be delivered if we are able to manage the burden that's coming from surgical backlog. So infectious disease historically held a larger burden in pediatric health group globally, and especially in lower and middle income countries. Even for our setup, you know that under 5 mortality still is being occupied with the early neonatal days, especially with poor the obstetric and neonatal care, prematurity, and infectious causes like TB, HIV, malaria. They are still posing significant mortality in our setup, which is a reality, but it's kind of slowly catching up for lower and middle income countries where we belong. Still, the infectious ones are huge burden, but now the surgical issue is still catching up, and in some contexts, they are even overpassing as the big challenge. So current estimates suggest that 85% of the children in lower and middle income countries may require surgery by age 15. This is the 1.7 part of the 1.7 billion children worldwide that we talked about earlier. And it's because of this that considering the development goals that were set in 2015, they considered surgical care as indispensable part of healthcare, because we cannot simply focus on treating the infectious issues, because in most of the countries it has almost catch up to the surgical backlog, or the surgical demand has catch up to the infectious cause of mortality. So this is a data that is gotten from UNICEF, which was published in 2017, and I'm going to be sharing with you a graph about that. So Africa's child population will reach 1 billion by 2055. So the reason we're talking about pediatric anesthesia is the surgical demand is also going to be significant in the coming few decades ahead of us. So the 1 billion children would be the population comprising in Africa, and it's going to be the largest child population in the world, while other parts of the world are dealing with life expectancy increment and associated old age population, but ours is kind of heading towards having more child population in the coming 2 to 3 decades. So we need to think about way earlier on how we can be able to get ahead of time, at least to prepare, try to meet some of the standards that are set by international organizations. And from 2017 onward, Sub-Saharan Africa is the region with the highest number of births. Hello, Blaine. Hello.
Yes, you are audible.
How about the screen?
This particular slide is visible, but the next one, I'm not sure.
Okay. What is being displayed on your screen? I'm talking about the key population stats from UNICEF. Is that the one that you're seeing now?
Yes, it is the one.
Okay. So, unlike other parts of the world, we need to understand that we are facing a huge burden in pediatric population demography. So we need to anticipate that one ahead of time and plan things ahead. So the changing demographics with the current projection is going to require additional 4.2 million health workers, more than the current number that we have. So this is also going to be a demand coming to our department. So the anesthesia providers for surgeries is going to be, it needs to be multiplied by manifold to at least fulfill the minimum WHO standards. So what is happening with my screen?
Doc, we are managing, our IT is managing just go on.
Okay. ماشي. So yeah, the things that I've talked already is just a graph showing
Sorry,
how.
let's pause for until we fix that.
Okay.
So let's play.
እንደ ሚቲንጋችን ሀክ ተደርጎ ነው እንዴ?
እየረበሹን ነው እንደዚህ አይነት ነገር
አዎ
ሰው እንዲገባ ብለን እንትን ሊንኩን ሼር ስላደረግን
አዎ
እንደዚህ አይነት ነገሮች ይመጣሉ። ለዛ ብለን ነበር ለኢንዲቪጁዋል እንትን የምናደርገው። ሰው አንዳንዱ ደግሞ መግባት ስላልቻለ ሼር ስላደረግን ነው። እንትንን ለመዝጋት እየሞከረ ነው። አትፍሩ፣ አይዞህ፣ ምንም አይሆንም።
እሺ እሺ
ሰብስክራይብድ የሆነ ዙም ስለሆነ ማኔጅ ይደረጋል።
እሺ
Okay, so shall we proceed with the presentation or is it going to be fixed?
ያ ፊክስ ያርጉትና
It's better to continue while our IT is fixing the problem.
እኔ ስክሪን ላይ ግን እንትን እያደረገብኝ ነው፣ ዲስፕሌይ እያደረገብኝ ነው እና በመሀል የተለያዩ ከለሮች ሁሉ እየመጡ ስላይዱ ሙሉ ለሙሉ ነው ከቨር እያደረገብኝ ያለው።
እያየን ነው። ትክክል ነው። አይ ጊዜ ከመጠቀም አንጻር ነው ሲከፍትልን ጋር ሞድ ይረብሻል። እግሪ እርታ
እሺ ኦኬ አሁን ደህና ይመስላል። አይ ቲንክ ዊ ካን ኮንቲኒው። ብሌን ዋት ዱ ዩ ቲንክ?
አይ ቀጥል።
I think
It is better
we
to
should
continue.
continue.
Yeah.
Okay. So this is just a graph showing the population demography that was projected on the UNICEF Data and Research Policy, published on October 2017. And as you can see, around on 2018 or something like that, the population is nearly half the child population. That means age 15 or less is comprising around 50% of most of the sub-Saharan African countries. Most of them having in the range of 45 to 50%. So that tells you a lot. And on that same paper, it is projected that currently Africa is accounting for approximately half of the child mortality globally. That is not only surgical, including the medical or the non-surgical conditions that we talked about already. The under 5 mortality from the communicable diseases and associated with malnutrition. And on top of that, we have also the surgical burden. And this is expected to rise around 50% for obvious reason, because the pediatrics age group is going to grow and reach around 1 billion in few decades. and the health workforce that is supposed to tackle all these issues is not achieving or meeting that number. Even the minimum standards are not projected to be met anytime soon. So the number of mortality, when you have the highest number of that group of population and you don't have the health workforce, the unfortunate scenario of having all the evils happening in your side of the globe is going to be a reality. So it's just to show you another global landscape of the surgical burdens. So as you can see, nearly 500,000 days are associated with congenital anomalies. And on the right side, you see WHO homepage data about childhood cancers, showing you the gross disparity in the burdens of disease and their outcomes. The outcome could be dictated by so many reasons, but as you can see, you see 80% of the children with childhood cancer are coming from the low and middle income countries. You see that the highest burden of the disease is in low and middle income countries, but at the same time, the survival is also way significantly low compared to higher income countries because of lots of things from infrastructure and workforce, from early detection and management modalities. So we're having the highest burden, but we also at the same time having the lower survival and highest mortality rate. At least to give you a clue about childhood cancer that can be treated. So this is the 54 million children need surgery is the one that I told you from 143 projected 143 million projected surgical demands globally. So coming to pediatric anesthesiology density in Africa, this is just to show you a small place called Tennessee in the US, in Texas, showing you the huge disproportion in the number of pediatrics anesthesia trained physician numbers. So you can see they have one pediatric anesthesiologist for 206,000 population in that district, but we have one in 26 million. So coming to the training sites to talk about the workforce, WFSA is to say World Federation of Society of Anesthesiologists. It's an association, it's a comprising associations from different countries worldwide, and it's one providing trainings in multiple sites throughout the world for physician anesthesiologists. And as you can see, it sponsors some of the programs in here, and you see around 7 training programs are already established in Africa, and 6 of them are in sub-Saharan Africa, being given in Ghana, Nigeria, Uganda, Kenya, Zambia, and South Africa. Some of them are on hold, but the other ones are actively training physician anesthesiologists. But the recruitment process and the number of graduates is not matching the growth in the population and the demand for pediatrics anesthesia trained professionals. So currently we have 128 million population in our country, It is from the World Data Reportal 2024 projected data. And as you can see from the picture, this is the pediatric anesthesiologists that are available in the country, all 5 of us. And there are only around 300 physician anesthesiologists. So we're still way behind what the standards suggest to meet the demand. So coming to the surgical outcomes, the reason we're talking about the workforce, the demand is also to see and understand where the gap lies so that we can intervene. By now, I'm sure you've picked that workforce is a huge challenge, but there are also other factors that come into play. So perioperative mortality for children undergoing surgery in Africa is 8-fold higher in Europe and North America. So this is African surgical outcome study for pediatrics that was done in July 2024, showing you even the surgeries that we've done so far. Their outcome is much worse even for the ones that we've intervened so far. So we need to also work on the quality as well, not only just the quantity. So we're lacking behind to do surgery. Now it is showing us that we are also lacking in delivering safe anesthesia and surgical service. So another study done in Kenya for around 10 years also showed that it was done in primary, secondary, and tertiary hospitals. It has shown significant mortality of the patients that they followed, and they kind of suggested it might be due to the inability to refer appropriate to the appropriate centers where there is a delay for the patients themselves showing up early in the disease course, and also their management, and lack of surgical and anesthetic expertise, and lack of specialized equipment and appropriate post-operative care. So it's like you don't have the workforce, you don't have, even from that one, you don't have high quality or high caliber trained professionals, and you also don't have the infrastructure to handle critical patients as well. So this is what the evidences show about what we are lacking in low and middle income countries, considering pediatric surgical and anesthesia service. So coming to the challenges, we kind of can classify in different form. The first one being patient factors. I think this is something that we are familiar with. Patient factors, pathologies that present for surgery are numerous and include congenital defects, infection, common pediatric surgical emergencies. So we have the large number of pediatrics age group needing surgery, and when you have large number, that can overwhelm the health infrastructure that you have. So it's from the large number that you can get large burden of surgically treatable disease, as you've seen from the previous slide. Even for the cancer illnesses, you've seen that the large number is lying in the lower and middle income countries. So it's just to say that there are too many patients for a very limited resource. The second one being lack of knowledge and awareness about treatment service. So I'm sure you've seen, like, I can give you an example. Even an urban city like Addis, families wouldn't bring their child when they have undescended testes. They just expect that thing to come down by its own, wait for years, and by the time they show up, it's already too late. And this is then you can't translate this one to other more threatening medical conditions or surgical conditions. So the health-seeking behavior of our society is lacking, and there is lots of misunderstanding. So by the time they show up, they are critically ill, demanding sophisticated management, which the country cannot simply provide. So from patient side, this is another challenge. And children who present for surgery are also, they could be having lots of comorbidities for the same reason. If the health-seeking behavior is not there, when the surgically treatable condition shows up, by then the child might be already anemic, malnourished, not being accompanied with the family, and wouldn't be able to get the appropriate care they should be getting, because families might not even want to stay with their child if the care is going to be kind of prolonged. So the equipment factor, this photo is taken from the country's biggest hospital, showing pediatric OR. And as you can see, when we're setting up an operating theater for pediatrics age group, it's different. So the way you treat a pediatric patient is not like an adult, and that is the reason we say pediatrics are not small adults. So the room needs to have its own setup, especially when you're dealing with preterm and term neonates, and this is a room where we give pediatric anesthesia service for the smallest human beings that you can find. So room temperature cannot be regulated. The OR setup needs to be child-friendly, which I think is more of a luxury in this setup. And monitoring devices are also meeting the standard ASA monitors that we considered: the blood pressure cuff, the pulse oximetry, ECG, intradistal CO2, the temperature probes. They are not available. So you just improvise with what you have. So this picture can tell you one of the reasons why the SOS suggested that we have 8 times fold increment in the perioperative mortality, even for the surgeries that we've done so far. So there are lots of things. Drugs are not available. We are only left to manage cases with few drugs, and your hands are kind of tied. The anesthetic equipment is, as you can see from this picture, even the ventilatory options in this for this room is not working. So one person is going to be dedicated to ventilate your patient while he can be productive doing something else.
Hello, can anyone hear him? Okay, I assume there is a connection problem on his side. Let me figure out and I will get back to you. Okay, not audible for everyone. Thank you for responding. Okay, Dr. Anteneh, can you hear us? Hello? Okay, I think we lost Dr. Anteneh. Maybe he has a problem on connection. So let's give him 5 more minutes. Yes, we have actually called him. I couldn't reach him. So we will give him 5 minutes so that he can return back. He can adjust his network maybe. Otherwise, we will continue with the rest of slides and discussions. I think the questions can be
Dr. Anteneh is coming back because there is a Farad gate in his vicinity. He's reconnecting using his mobile.
Okay, so let's wait a couple of minutes and the questions is better to be afterwards. So we will continue with him. Very sorry for the inconvenience, everyone. He will be back in a minute, and thank you very much for your patience.
ብሌን ይታያል?
Welcome back. Yes, ይታያል.
What a perfect timing to talk about challenges. So I was literally ready for every possible scenarios, but still the challenge that you can get in this country is just so unpredictable. So
Yeah, we will call this as equipment factor, one of our equipment factors, right?
exactly.
Okay,
Okay,
please
so
proceed.
okay, thank you. So, as you can see, we were talking about the lack of drugs that are available to us to provide a safe and quality anesthesia service to our patients. And we're lacking the basic anesthesia equipment. As you can see, you don't have a continuous medical air service in your room. You don't have the anesthesia gas. As you can see, there is only one vaporizer available, and probably it's going to be halothane, which is outdated and it's no more in production and obsolete in the rest of the world. But we are still using it to manage the most critical patients in our setup because we don't have anything else, and they are only left with getting that surgery with whatever we have, or just die with no intervention. So that is the scenario we're facing. The monitoring devices, you can see, and I've already told you that most of our anesthesia machines and ventilatory machines that we have are not tailored to our patients' need, and we need to improvise with whatever we have. And this is one of the examples of that improvisation. So coming to local system and infrastructure issues, patients may face delays in receiving their surgeries, and you know that there are long list of waiting to have the surgery, especially in surgical patients like head and neck surgery areas, tonsillectomies. They have long lists. So for those who are coming from very far, they just get tired of waiting, and they don't have the infrastructure to visit public hospitals for so many reasons, and they simply cannot come. And by the time they show up, it's going to be for an emergency surgery. We don't have the exact adequate infrastructures for accepting those patients as well. So, and there is also financial burden that the family cannot simply handle. So even if they are willing and able to bring their child to the health centers, they simply cannot afford the care and the payments for that care. The other factor being, even after delivering the appropriate care, this is something that we face, especially when we're dealing with critically ill children and the small ones like neonates. We work on a patient who actually could have a good outcome post-operative, but we simply don't have the personnel or the facilities to manage them post-operatively, because surgical care is not just one-time thing. You simply cannot just operate and leave the patient to go home right away. So our hospitals are not equipped well to handle that kind of challenge as well. So we might do well handling very critical child in the OR, but our hands are tied to manage them post-operatively, and one of the reasons why our perioperative mortality is significantly higher. Systems for clinical governance are unlikely to exist. So unless you analyze the problems that you have, know the gaps and address them, then it's just your effort is going to be futile. You're not going to manage the whole healthcare delivery process efficiently. I should have brought this one as a first reason, but human resource is a big challenge. But I think we will address that part in the workforce discussion in the earlier slides. So, opportunities. So whenever the problem itself offers you opportunities to analyze, see the gaps, and work on the things that you can modify. So in our setup, we have the patients. So if we are going to train people, get exposed to the disease and analyze the means that we can intervene, the problem is always there for us to work on. So one of the opportunities is just the problem itself. And coming to the physician anesthesia providers, whom we expect to be the leaders and educators in enhancing the safety and the quality of pediatric anesthesia service. One is pediatric anesthesia training in Africa. So this is an established program for Sub-Saharan Africa where they get to, with a collaboration of international donors. They are giving training currently at 4 countries, the one that you saw previously. And we're trying our best to have that opportunity to come to our country, because this training not only trains physician anesthesiologists for fellowship, but it also has lots of training opportunities for non-physician anesthesia providers, where we get to have them be trained for the common challenges that we face during the provision of pediatric anesthesia. So one of the opportunities is PATA. It's called PATA. It's a pediatric anesthesia training in Africa. Associated with that, we have also technologies that would enable for distant teachers to enrich local educators. So it's not like before that currently we get to have various modes of communications from people that are very far, who can train without the need for them to come here. So this program has its own privilege, where they get to facilitate an online form of modules that can be accessed for anesthesia providers to update themselves about the current advancements in the safe pediatric anesthesia provision. In partnership and collaboration with local and international stakeholders, yeah, whenever you have the problem, then there is always a room for collaboration, be it from local and international stakeholders. So coming to solutions, one is establishing training sites and institutions dedicated for pediatric service. So, I mean, like when having an established pediatric surgical center handling the burdens specific for the surgical demand is going to help in way of the proper utilization of the energy that you have to be spent on a big problem that we've seen so far, a mortality that can be significantly reduced. So the training sites, the fellowship programs, and the specific trainings that are associated with it is going to be one of the go-ahead things to expand the training pediatric anesthesiologists as educators and leaders. This is something that I have already addressed. And capacity building of personnel involved in the perioperative management of pediatric surgical patients. As you know, any surgical patient is not just one team managing them, especially the more critical they are. The large group of professionals are going to be involved in their management. So the nursing team, the anesthesia providers, the surgical team, the ICU team, we need to have organized way of quality improvement projects to address the huge gap in the quality of safe pediatric anesthesia service provision. Then hiring and retaining professional. I think this one works for every profession because now we are suffering from losing our profession to highest bidders, I guess. and incorporating it in national health policies. I think the Ministry of Health already has a clear roadmap in enhancing the specialty subspecialty roadmap to incorporate highest level trained professionals to be a leader of that specific field. And this one has already been well backed with evidences. Different studies from Europe and in Africa, from Kenya and Niger, have clearly shown, especially in pediatric anesthesia service provision, the more advanced the anesthesia provider is on that field, based on their training, the better the outcome. So we need to incorporate, which is, I think, it's already incorporated in the Ministry of Health policy on expanding the specialty and subspecialty roadmap. And finally, providing more evidence of the challenges with the research. So we've listed on the reasons previously from patient factor, infrastructure reasons. We just need to show the decision makers with evidences so that they can actually come and intervene exactly at the site. So, summary, there is a huge gap to be addressed in safe pediatric anesthesia provision in the country, not only in the country, in the lower and middle income countries overall. And safe anesthesia is not necessarily the most expensive one, because we can still utilize with good clinical governance, make a good use of whatever we have in here. Thank you very much.
Okay. Thank you very much, Dr. Anteneh, for the elaborated presentation. Even though it was there were some discontinuation in between, you just made it on time, and it was a very detailed presentation. Thank you. So now the floor will be open. Unclear points or any discussion points will be welcome. You can raise your hands, or you can drop me on the chat box. I can get that. Okay, so until I see any hand or any question, there was one comment citation. I think it is doctor was one of the most common causes of death after surgery in pediatrics from my observation. So what do you think about this, Dr. Anteneh? Is hypothermia a challenge in our situation, and can we say it is the commonest cause of death perioperatively or after surgery? Can you reflect on this statement?
Okay, Blaine, let me make sure if I have heard you well. So you were asking about the challenge we face with hypothermia, right?
Yes, actually, there was one comment while you were presenting on equipment challenges. There was a comment that said hypothermia was one of the most common causes of days after surgery. Um, as just, do you agree or do you disagree? What's your input on this one?
I'm really sorry ብሌን የተቋረጠ ነበረ እና በደንብ አልተሰማኝም ያልሽው ነገር።
Okay. I can repeat it again. Thermia in our situation. What is the current existing condition? There was one comment actually from one of the participants stating that hypothermia was one of the most common cause of days after surgery in pediatric in our patients. This is actually from my observation, he said. So what do you think about this comment?
Yeah,
Is that clear?
I displayed this. Yeah, I've heard you now. So the reason I displayed this room is it might not be visible enough, but operating theater's temperature is not regulated. And you know that this is one of the high altitude places in Africa where you get to have lower temperature recurrence throughout the year, which you cannot simply compensate for in your operating theaters. And you know that one of the causes for morbidity and mortality in our or in general in pediatrics age group is hypothermia, where you expect the room temperature of your operating theater should be ranging is depending on the age of the patient you're working on from 26 to as high as 34. But you know, even for morning surgeries, the temperature could be less than 10 degrees centigrade at times because of this altitude. So temperature regulation is a very crucial and important issue. It's something that we've observed so far. Most of our operating theaters, they don't have the modality, let alone to manage the room temperature, but to even measure the temperature of the patient. So for objective reporting, you don't have even the recordings of the patients, let alone the room temperature being regulated. But from your simple observation, you can deduce that hypothermia is a huge issue. And we've seen it so far, especially when dealing with neonates, infants, you expect the room temperature to be much higher than the one that we're working on currently. And you know that radiation is the most common means of for losing temperature for pediatrics age group, and we simply cannot compensate for that by just simply using warm clothes. It's just simply cannot help that much. So it's a huge challenge, and I kind of share your concern.
Okay. Thank you very much. And I think that's a very valid and good point. We think that hypothermia is still one of the commonest causes of at least morbidity in pediatric patients perioperatively going for surgery. However, as you said, we need more research, and it will be a nice field to research on this issue. Okay, thank you. Then there is also another question that says, how do you see patients misunderstanding the challenges?
So
Uh,
I don't know. Mute ማድረግ የሚቻል ከሆነ I think there is noise in the background.
Can you further elaborate the question? I don't know who asked
It's okay.
this one.
I understand አድርጌዋለሁ. So he's asking about how we can address
Approach the patient's misunderstanding of the challenge that we have probably. What approach should we take in order to have against patient misunderstanding.
So, to speak from the anesthesia perspective, the good side is lately we are encouraging hospitals to have their own separate pre-anesthesia clinic where they get to spend enough time with their patient to advise them what to anticipate during their surgery from anesthesia perspective, what are the expected challenges, complications, and what to anticipate even post-operatively. So whenever you have the chance to discuss with the family, you need to be able to spend as much time as possible to inform them on the perioperative anesthesia management of your patient. Sometimes, yeah, it's a kind of culture that we are trying to change, but people, when they are coming for surgery, they barely have any information about anesthesia. So encouraging to have pre-anesthesia clinics where you get to spend enough time to explain to them would definitely help in the knowledge and awareness gap that you might face considering the anesthesia service. I hope I
Okay.
addressed.
Yes, I think you have addressed the question as well. If it is not unclear, we expect the one who has questioned to question it or rephrase it again. So we can jump to the next question. Okay, so there was also a question that says, is there any training program to increase the quality of care that's provided by NICU nurses, healthcare providers, and anesthetists in the perioperative care? So you have mentioned about training um, as solution of healthcare workers. They're asking for any training program for the perioperative pediatric for care providers.
So, so currently, as part of the PATA program that I was talking about earlier, at least we are expected to provide at least 2 trainings for anesthesia providers for pediatrics, at least managing emergencies in pediatric anesthesia, where we get to pick common pediatric emergencies in the perioperative environment and get to train them about the management, the whole approach of managing those emergencies. And there is also a course called Safe PEDS. It's more or less similar. Both of them are kind of simulation based, unlike the previous type of trainings. The previous one where like you get to sit, lectures will be delivered, and probably you'd be bored after the second or the third day, and you wouldn't be able to even remember some of the basic things that were mentioned. But these ones are kind of simulation based, where you get to practice hands-on on addressing the big I say like the skill and knowledge gaps that you've been facing during your practice. So they are more based on about hands-on and close to reality type of trainings. For pediatrics and neonatal, we are in collaboration with the Ministry of Health, we are trying to we are actually on the process of writing up a training manual for pediatric ICU as well. And we try our best to make that one as just like the hands-on training that we've already talked about, the MEPA and the Safe PEDS. But it's something that is ongoing. So for the anesthesia providers, there is already established trainings that we expect to run it in the coming years. Anything more you want to add on that? Then
Yes, I actually can't agree more with you. So there are actually ongoing trainings, as you have mentioned, like safe beds or trainings on associated with other professionals in the period. But the question is, are they in our perioperative care providers to the level that we want them? Is a question, and it also needs further research to feeling that it's not enough. It's not in every facilities that in every areas that it is not reachable. So because of these reasons, I think we need more training uh, sites, more trained people, and it's a valid comment that there should be a continuous or an ongoing training of health professionals for capacity building or for adding more skill or knowledge. So yes, it's a valid point. We need more training programs for already on work or to recruit more ones. Yeah.
any more questions?
So yeah, and I can't see any other more question. There are actually more comments that also emphasizes on perioperative fluid management in pediatrics. Hypoglycemia management is not enough, as well as pain management. Yeah, these are actually very important things. So what is the challenge behind this is the discussion of our point. Yeah. So yeah, so we have discussed what is the challenge, why we are not having adequate fluid management, why we are not having adequate pain control or glucose control in our perioperative care patients. That's what Dr. Anteneh has been showing us. He has been showing us actually the burden of our challenges. What is the demand versus the workforce, and what is the challenge in terms of patient, in terms of equipment, in terms of local systems. And he has also shown us that these problems can actually fall into opportunities. And he has cited the solutions for the problems that has been listed. So, do you want to reflect on the statement that says perioperative fluid management, glucose control, as well as pain management is not adequately managed, Dr. Anteneh?
Honestly speaking, we should be preparing another presentation to discuss specific details about that. And for anyone interested on that topic, I can literally prepare a presentation for that. But it's kind of can be summarized in the capacity building part of the discussion, because when you have a team that is capable of addressing the challenges, the perioperative anatomy, physiology, and pharmacologic changes of pediatric patients, these things can be easily managed. But for a presentation like this one, I think, let's say that it's a big challenge that we're facing, but it's gonna be beyond the scope of this discussion.
Great. I think that's a marvelous idea. So we may be having another presentation in detail about these conditions. One more question I have seen is, how do you feel about the practice in Ethiopia, surgeon based the setup? I think this is to mean, is it a challenge that the surgery is also facing a setup problem, that it is also a pediatric anesthesia problem? I think it is to mean like that.
I'm not sure if I got the question right, but let me answer from the point of view that I've understood. So previously, and there is one thing that I normally want to repeat to everyone whenever I get the opportunity. So surgery has been there for like 4 centuries, but there were two things that changed the kind of the course of the surgery provision. I mean, the quality of the surgery that we provide. One is the invention of antibiotics. The second one is being anesthesia. In our country, it's has been a challenge. It was not getting the proper attention and level of respect it's expected to have, but it's kind of improving lately. So we need to really emphasize the importance of anesthesia on the outcome of your surgery, especially the complicated ones. So, and it is something that is backed with evidence, and one of the factors for deciding the outcome of your patient is how skilled and how capable the personnel doing the procedure is. This works for the surgical department and this works for the anesthesia as well. So it's a work in progress. It's something that we need to work on, and it is something that is I hope it's something that is moving maybe like in the right direction.
Yes, I think you have addressed this question. If not clear, you can use the inbox for more questions. Otherwise, we are running out of time. I want to thank everyone for the active participation and for your nice questions and for the discussions. So we have like 10 minutes for the questions. If there is no any other burning question or burning point to be raised, I think we can display the questions and the audience can answer those questions. Thank you very much, Dr. Anteneh. Thank you very much, everyone, for the nice presentation.
Thank you, Dr. Blaine.
Thank you, Dr. Anteneh, Dr. Blaine, for your time, for your commitment. Almost you invested nearly 1 month on the communication and everything. We are so grateful, and I want to say thank you on behalf of IMA. And the question is displayed for the participant. The question link is already posted in the chat box. Participants can attempt the question and earn 1.5 CEU after when they score 15 and above. Thank you very much. I thank you also the participants for your time. Thank you all. See you tomorrow on another CME topic, which starts at 11 a.m. and then afternoon on the coronary disease at 2 p.m. Thank you very much. Thank you, Dr. Anteneh and Dr. Blaine and the department all, IMA crew who promoted and who controlled the IT challenges. Thank you very much.